Good day, my dear postgraduate students. Welcome to the encouraging session of Glide the Slide, Group C, the third slide of it. And R.A.T.S welcomes you to it. There is a history as usual, non-puerperal. Probably the patient is not lactating, not in the reproductive age, 45 years of age with an onion peel skin appearance. And this is the tissue. So I think too much of a clue has been given, and I would like you people to appreciate what is here. Whenever a slide is given, do not be biased. I would like you people to appreciate whether it is a solid or a glandular tissue. Are you able to see the ducts or no? What are you finding lining the ducts? And then what do you find filling the ducts? And of course, what is the supporting stroma? What infiltration it has got? So this will be the sequence with which we shall go. So I am finding that there is dilatation of the ducts. So there is a dilated duct that is over here, and it is filled with foamy histiocytes. Foamy in the sense it has got very fine vacuoles. The nucleus will be slightly eccentric, but not pushed to the periphery as in the case of a fat cell. And there is infiltration in the wall, which are lymphocytic. Sometimes it can be plasmacytic. So dilatation with secretions and foamy macrophages and infiltration of the spore. The clinical features can be thus. The patient is usually 40 to 70 years of age, rarely in the childbearing age. There can be a pain, nipple discharge as is shown. And when the clinician palpates, it is a duffy and worm-like structure that is subareolar in location. It can be mistaken for a malignancy because there can be a fixity and the slight retraction of the nipple. Mammogram also unfortunately mimics a ductal carcinoma in situ. The gross description will be like this. It is a firm fibrotic breast tissue with dilatation and thick wall ducts. That is why you are able to get a worm-like feel. There can be a tan white or a creamy or a colored pasty excretion or a secretion. Calcifications with abscess formation can be displayed on the X-ray particularly. The site, please do remember, it is extralobular, not within the lobules. It is retroalveolar. It can be bilateral. Important points that we should remember. Etiology is not well known. Probably it is because of the involution of the breast in the perimenopausal women. Leakage of lipid-rich material leading to stasis. Then there is a periductal inflammation, fibrosis, and probably stretching, just like bronchiectasis. Sometimes there can be sclerosis, stasis, and that can lead to a duct ectasia. Strangely, smoking and phenothiazine are acquainted with it. There is also a syndrome called as SMALT, squamous metaplasia of lactiferous ducts. So it is a disorder of the extralobular ducts. Different degree of inflammation, periductal fibrosis, foamy histiocytes, infiltration of the walls. This we have already mentioned. And this is yet another slide that we are seeing. Look at this distended multiple foamy histiocytes. There is a luminal secretion. This is not white as I would appreciate in this region. Kindly compare both. And within the wall, I am finding the epithelium of the involved duct. Periductal inflammation. Thin fibrosis is seen and dot-like inflammation. Lymphocytes. If you are lucky enough, you may see plasma cells. And this is again the glandular tissue that is seen more towards the periphery. Periductal fibrosis in the later stage. Grossly and radiologically, this will be the firm fibrotic tissue. And when a mammogram is done, there can be calcification as well as a resemblance to ductal carcinoma in situ. There are the different stages in this: dilatation, acute inflammation, abscess formation. And lack of radiological specifications can be there. This is the mimicry. And some serum markers can be used for making a diagnosis. So look at this picture, much better. I would like you to kindly see this. So there is a periductal inflammation and there is a lining of two layers, probably the basal and the myoepithelial, then the epithelium. There is no piling up, there is no pleomorphism that could be seen. And look at the amorphous material that has collected within the ducts. There is a stasis, obviously inflammation. Also, I would like you people to kindly appreciate the cholesterolic birefringence that is appreciated in the secretion. Periductal fibrosis can be a later one. Strangely, there can be multinucleated giant cells. We should be a little careful about it. And this periphery of inflammation has been described as the Garnet sign. So these are the references. These are the names for it. Duct ectasia or mastitis obliterans or chlamydomastitis. These terms are rarely used. So we have come to the diagnosis. And my question is, what is plasma cell mastitis? And these are wonderful references which I would like you people very much to go to. Thank you.